discuss with you some aspects of daily treatment of osteoarthritis, obviously from the viewpoint of a rheumatologist, but this is a kind of overlapping topic we share together. First of all, I want to talk about the EULAR recommendations for the management of osteoarthritis, just the format, how those recommendations are elaborated. And this is the first step in elaborating those recommendations. The key recommendations expressed by the members of the panel. Afterwards, there's a search of the evidence for efficacy, a search for safety, cost issues, but also for availability and perceived patient acceptance or adherence. Afterwards, there's quality scoring of the papers, and then determining the category of evidence and the strength of recommendation accordingly. So the Delphi process is the crucial process of elaborating those recommendations. And the Delphi process starts with an email round where the members of the panel mail 10 propositions, in this case diagnosis proposition or management propositions. Those propositions are then rephrased, the list is recirculated, and the members of the panel vote on the favorite 10 proposition. Afterwards, the list is reduced according to the support by the members of the panel, and as you can see in the following Delphi rounds, those recommendations not achieving support of more than 5 members of the panel were not retained within the process. Just to remind you briefly on the Oxford system for the categorization of the levels of evidence and the derived strength of recommendations for example, therapeutic modalities. And just in brief, the EULAR recommendations for the management of knee-OA. In red, this is the recommendation which relates to possible structure modifying capacity, and in blue, these are the caveats which were expressed for the Susadua group in those recommendations. In the same way, recommendations for the management of hip OA were elaborated by almost the same panel, including rheumatologists, orthopedic surgeons, epidemiologists, and there were only slight differences in those recommendations, namely number 5, the topical application of NSAIDs was recommended on the knee level only, and for the management of hip OA, a second surgical procedure, namely osteotomy and other joint preserving surgical procedures were introduced, while in the recommendations for knee OA, only one surgical recommendations was included. This is an interesting slide, I think, because it shows you the few number of publications dealing with the treatment of hand OA, despite the fact that hand OA is a common problem in Europe and is a really frequent disease. But the number of publications dealing with this disease is relatively small. Therefore, the task force decided to invent a different form to determine the strength of recommendation as expressed by a VAS to be completed by the members of the panel and a 5-point rating scale. And what you can see here is the compiled agreement of the members of the task force in relation to the single recommendations. You can see here complete agreement with the first one, but for example, relatively low compiled agreement for example, local heat. That means paraffin wax or hot pack application in cases of hand OA. And these are the other recommendations for this disease. So summing up the EULAR recommendations for the management of osteoarthritis, it was possible to achieve a continent-wide consensus, which is not always easy, given the different cultural background of many European countries. We found evidence primarily available for knee OA. For hip OA, most frequently there was combined evidence for knee and hip OA, and with relation to literature evidence, hand OA was found to be more or less a forgotten disease regarding the number of publications. So the strengths of these recommendations are the scope, the rigor of development, and we are convinced also their clarity. The methods used to synthesize research evidence and the experts' opinions seem to be robust, although there are obviously some weaknesses. There is a lack of stakeholder involvement. Applicability of those recommendations has to be proven in the future, and editorial independence is also a matter of discussion, as all those recommendations are published in the EULAR journal, namely the Annals of Rheumatic Diseases. In comparison to the recently published ORC guidelines, one has to remark that the ORC guidelines are much more comprehensive. That means that the intention of those guidelines obviously was to include all modalities which are available, while EULAR recommendations per se accept the restriction with the number of recommendations. Also, the panel of the EULAR recommendations included much more rheumatologists than the panel developing the ORC guidelines, but there are in fact not so many differences between those guidelines for the management of knee-OA. This slide is a kind of a bridge to the second part of my talk, which will deal with meta-analyses of the Diacerein in the treatment of osteoarthritis, and this was the title page of our own meta-analysis published by Burkhard in 2006 in the Archives of Internal Medicine. And I will also try to discuss with you the Cochrane report by Fidelix in the same year, and the most recently, namely 14 days ago, published meta-analysis by Bartels from Norway. I know this is a very busy slide, but these are the numbers of publication included in our own meta-analysis, namely 19 out of primarily found 23. So it was our intention to be as comprehensive as possible at that time, as we were not aware that simultaneously the Brazilians performed a meta-analysis, so we thought we were the first to do. And what you can see here, the number of patients totally included amounts to more than 2,600. As the publications with Diacerein are not really heterogeneous, that means some compare the substance with placebo, the others with active controls, mostly NSAIDs. We divided the studies according to the comparator substance. The distribution of joints treated with the drug are comparable to the common literature. It were primarily studies dealing with knee-OA. Only in 11% the studies dealt with hip-OA, and in approximately half of the studies dealt with knee and hip-OA. The duration of treatment was different, you see, from 1 to 36 months, and also the duration of the challenge period differed from 1 to 3 months. It's remarkable to say that 8 of the studies were published in peer-reviewed journal with an average impact factor of 4.1. These are the statistics, and in contrast, for example, to the Bartels trial, we used GLASS scores, which is also a standardized mean difference, and it's noteworthy to say that GLASS scores higher than 0.8 are commonly regarded as clinically relevant. We also performed quality scoring according to the JADAT score, and what you can see here is the average JADAT score of all the trials amounted to 3.2. JADAT scores are ranging from 0 to 5, so it's above average. And in brief, the non-weighted pain results at the end of the active treatment period versus placebo, which revealed superiority of Diacerein over placebo. 2 trials were inconclusive. The most of the trials favored Diacerein. This is the same for the comparison of Diacerein and non-steroidals. There is no statistically significant difference difference between diacerein and non-steroidals during the active treatment phase, but during the de-challenge period, there was a superiority of diacerein indicating a carryover effect of the substance. So in summary, these are the analyses we did. We did additionally sample size weighted analysis and Chadat score weighted analysis, which revealed the same results as the non-weighted analyses of the comparison of diacerein and the comparator substances. That means that we found in a very comprehensive meta-analysis superiority of diacerein over placebo regarding pain reduction and improvement of function, and an equal efficacy of the substance compared to NSAIDs. We also found a proof for a carryover effect, which was later on proven in a controlled trial, and regarding tolerability, we found no statistically significant difference between diacerein and NSAIDs, and obviously a superiority of placebo over diacerein regarding tolerability. As I said before, simultaneously the Brazilians performed a meta-analysis of diacerein with the same objective we had. They included the trials according to the Chadat score, indicating that only trials achieving a Chadat score of 4 and 5 had been included into their meta-analyses. So they finally ended up with 7 randomized controlled trials. And I want to pay your attention to the Dugados trial, which is the EULAR trial, which was a truly structure-modifying trial in HIPPO-A, and the FUN trial, which was a combined Sysadwa DMOID trial in NEO-A. So in fact, these were 5 trials dealing with symptomatic efficacy and 2 trials primarily dealing with structural efficacy of the drug. Nevertheless, regarding pain reduction, the results were very similar to our own meta-analyses. Pain reduction was equivalent to that of NSAIDs, and it was shown that diacerein was superior in comparison to placebo with respect to pain reduction. And this is the abstract of the most recent meta-analysis published 14 days ago. Is a full paper, but this abstract was presented at the EULAR in Copenhagen, and I found the last sentence of the conclusion remarkable. There is a possibility that there will be no symptomatic benefit following more than 6-month therapy. As a clinician, I'm convinced that this is relevant for any treatment you apply in any disease, because you cannot never be safe that the treatment is working 6 months after initiation. However, what you can see here are the trials included into this meta-analysis, and you see the high degree of heterogeneity regarding the trial duration. So this statement is based on primarily 2 trials, which were longer lasting, namely 12 months and 36 months, and those trials were structure-modifying trials not targeting primarily symptomatic efficacy. So the conclusion is somewhat irrobust to my opinion, as it, as I said, is derived from structure-modifying trials. Just to show you the plots for pain, and pain showed an effect size of 0.24, and for function, which showed a small effect size of 0.14 in favor of diacerein. The main issue in analyzing meta-analysis is another meta-analysis which was performed from the Nottingham group dealing with the placebo effect, and I want to pay your attention on the effect size for pain relief exerted by placebo. This pain relieving effect increased when the active treatment effect increased, when the baseline pain was high, and when placebo was given through injections. That means that the placebo effect is dependent on many issues, including the way of application placebo. So, as my time has gone by, I'm going to be a bit quicker. So the shortcomings of conventional meta-analysis are listed here, and it's a bit like the stories of apples and pears. You should avoid to compare apples and pears. That means the endpoints of the studies are of importance, the efficacy criteria, the populations, whether you are very restrictive, whether you try to be as comprehensive as possible, whether you use quality scoring, whether you use the same comparators. So you should keep those selection criteria in performing meta-analyses, and I would very much prefer, and this would be the only meta-analysis I would do now for those substances, a meta-analysis based on raw data, because raw data give you the possibility to more or less create a new study population and to evaluate the variations of the studies and to adjust for heterogeneity. Additionally, and this is well known, there is a correlation between the effect size and the trial duration as a continuous variable, which you can see here in a trial which dealt with NSAIDs and was published in 2000. What you can see here, that the effect of those treatments during the duration of the treatment becomes very, very comparable throughout the treatment time. And what I show you just before the end of my talk, that most of the trials dealing with structure modifying capacities of D modes were symptomatically negative. Therefore, as a kind of a research agenda, I would propose meta-analyses on raw data of trials targeting symptomatic efficacy. That means targeting the improvement of pain of function, which is essential for the patients in daily living activities. Thank you for your attention.